Good day, everyone. I am Christine, the moderator for this webinar. I welcome everyone to today's webinar, the CMS Hospital Infection Prevention and Control and Antibiotic Stewardship Program. I would like to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, PSJD, RN, CBHRM, recently served as the Regional Director of Risk Management and Patient Safety for Kaiser Permanente Colorado. Laura holds a Bachelor of Science degrees from Regis University, recep of Denver, a Doctor of Jurisprudence degree from Drake University College of Law, Des Moines, Iowa, and a registered nurse diploma from St. Luke's School of Professional Nursing. I would like to hand over the floor to the speaker. Over to you, Laura.
Okay, thank you very much, Christine, and welcome everyone. As Christine mentioned, our topic today is something that's undergone some changes over the last 5-6 years. And of course, with all of the emerging infectious disease and then some that have been around for a while but still seem to crop up, such as influenza, they made some additional changes to these requirements. And that's what we're going to talk about today, along with the traditional conditions of participation. They didn't have performance improvement on infection control issues. They weren't cleaning glucometers or the nebulizer between uses. They didn't pre-soak dirty surgical equipment so it could be properly sterilized and then repackaged. So I'm going to start right off with infection prevention and control. I have the tag numbers. A means that is your appendix, Appendix A for acutes. I'll get to criticals in just a bit. But let's start with Appendix A. Back in 2019, they did a massive overhaul with what was called the Improvement in Patient Care Rule. So for and prevention and control, years and years ago, we used to call this infection control. What does your program have to show? This is a must. It's not a should, but a must. One thing, they want to look at your policy and procedures. They came up with this new changes, some new wording. Infection preventionist. The program always has to rely on your policies and procedures. You have to focus on your efforts to control and prevent these infections at all levels. It is also very imperative that you look at your multi-drug resistant organisms of your healthcare associated infections. Unfortunately, they had to say, we have to keep our place clean and sanitary. So water management. Again, hospital-wide surveillance so we can identify those risks at any location so you know what to do, so you know how to diagnose and manage those cases. During a public health emergency, this is the emergency, you have certain reporting requirements that you have to do. Now, just recently, in fact, November of last year, 2024, there were some updates to our reporting requirements. In fact, what they did was they reviewed and renewed and revised what we now have to report on our respiratory infections. This is limited to respiratory infections. All hospitals, that includes criticals. You have to report, you have to submit daily data values on a weekly basis to the NHSM. A lot of benefits here. Doing that 1 day a week snapshot and weekly total, it's a new pathway for weekly reporting. It has to reflect the services and complexity of what you're providing. And the CDC and CMS came together and they issued a joint statement. So there are certain reporting requirements. I'm going to flip over now to Antibiotic Stewardship Program. Tag numbers, there's about 21 of them. Again, this is pretty new. This is what they did back in 2019, 2020. A lot of the requirements are not in the current 24 manual. Starting with the first tag number, you have to demonstrate that you have someone who is qualified through education, training, or experience in infectious diseases and or antibiotic stewardship program. We have to make sure, of course, they're qualified to improve prescribing of antibiotics. CMS, and again, CDC, they talked about that interoperability program. Like with anything, we have to have documentation, nationally recognized guidelines and best practices. They have a lot of responsibility. They have to make sure you have systems. Policies, they should address what are the roles and responsibilities of infection prevention and control. ASP, same thing. They bring QAPI leadership. They now have the responsibilities of the preventionist and later on the antibiotic stewardship. They have to document what they have done, their program and their activities, their surveillance and control. The preventionist also has to communicate and collaborate with QAPI. The preventionist also has to audit personnel's adherence to policy and procedures. Likewise, the leader of the ASP, they also communicate and collaborate with the medical staff, nursing, pharmacy. They also have to educate folks. If you are in this area, a unified integrated program. This is for multi-hospital systems. It is not including critical access hospitals. You have to have a way, a mechanism to make sure issues localized to one or two hospitals are considered. So I'm just going to talk now a few memos on infection control. Insulin pens. The next one is single-dose vials. Breaches, infection control breaches. The memo came out. Legionellas. That's one that we still have to report. I want to talk briefly now about the CDC, the ASP, and the core elements. They updated it in 2019. And then we want to talk about disinfecting, cleaning, or sterilizing of our reusable medical devices. You always want to separate what's critical and what's semi-critical items. Infection control resources, there are changing sections on PPEs. And then I just want to wrap up with some of the other things. Thank you again, Christine. Thank you for all the attendees. With that, I'll have Christine end it all. Take care of it and close it out.
Thank you, Laura. Thank you, Laura. That concludes the session for today. Thank you, everyone, for participating. You may all disconnect now and have a wonderful day.